RealMind Biotech, specializing in the advancement of chemiluminescence immunoassay platforms. With dedicated R&D and precision manufacturing of comprehensive reagent kits, committed to self-reliant pioneering breakthrough innovations. We advance medical technologies to serve the public. Introducing the fully automated Chemiluminescence Analyzer MCL60, having a compact design, but still pursuing the combination of precision and efficiency. It's also the most efficient CLIA device per unit area. MCL60 uses magnetic microbeads acridinium ester CLIA method, improving the detection precision to within 3%, while the sensitivity is up to 0.4 picogram per milliliter. The analyzer supports serum, plasma, whole blood, and capillary blood testing while on the selected tube used. Monitors sample pipetting, incubation, detection, and washing throughout the test process. Ensure the accuracy and reliability of every results. MCL60 has a high throughput detection of 144 tests per hour, first result in 12 minutes, while having an ultimate integrated design. It can support up to 20 samples and 8 reagent positions with HCT module. To ensure quality, results of whole blood samples truly achieves 24/7 testing and with 192 individual vessels. Clinician-validated intuitive interface enables minimal training, even for first-time users. RealMind MCL60 accurate and effectively on cardiac markers, inflammation monitoring, growth and development, reproductive function, cytokines, thrombus, cerebral injury, and more. Professional clinical service, specialized in clinical rapid and precise diagnostics, dealing with compassion, advancing medical frontiers. RealMind Biotech for better diagnosis. RealMind Biotech, specializing in the advancement of chemiluminescence immunoassay platforms. With dedicated R&D and precision manufacturing of comprehensive reagent kits, committed to self-reliant pioneering breakthrough innovations. We advance medical technologies to serve the public. Introducing the fully automated Chemiluminescence Analyzer MCL60, having a compact design, but still pursuing the combination of precision and efficiency. It's also the most efficient CLIA device per unit area. MCL60 uses magnetic microbeads acridinium ester CLIA method, improving the detection precision to within 3%, while the sensitivity is up to 0.4 picogram per milliliter. The analyzer supports serum, plasma, whole blood, and capillary blood testing while on the selected tube used. Monitors sample pipetting, incubation, detection, and washing throughout the test process. Ensure the accuracy and reliability of every result. MCL60 has a high throughput detection of 144 tests per hour, first result in 12 minutes, while having an ultimate integrated design. It can support up to 20 samples and 8 reagent positions with HCT module. To ensure quality, results of whole blood samples truly achieves 24/7 testing and with 192 individual vessels. Clinician-validated intuitive interface enables minimal training, even for first-time users. RealMind MCL60 accurate and effectively on cardiac markers, inflammation monitoring, growth and development, reproductive function, cytokines, thrombus, cerebral injury, and more. Professional clinical service, specialized in clinical rapid and precise diagnostics, dealing with compassion, advancing medical frontiers. RealMind Biotech for better diagnosis.
Good evening once again, ladies and gentlemen. For those who have already finished your dinner, you may now kindly take your seat. We will begin the program shortly. Thank you very much. Good evening once again. On behalf of BioBase Myanmar and Riaman Biotech, I am truly honored to welcome you all to today's continuing medical education program titled Current 30 for Emergency Management. We sincerely appreciate your presence and your commitment to advancing clinical practice and emergency care in Myanmar. My name is Susanna Pyo, and I have the pleasure of serving as your master of ceremony for this evening. Today, continuing medical education program will be guided by the following ajana. Ajana 1, opening speech by Dr. Joming. Ajana 2, welcome remark and introduction of workshop team and ajana by Dr. Wim Yau. Ajana 3, Current 30 for emergency management by Dr. Sujita Nai. Ajana 4, Real-Mind Whole Blood Cardiac Marker, performance and clinical application by Scotty, Real-Mind Marketing Specialist. Ajana 5, practical experience sharing by Dr. Zawang. Ajana 6, performance validation of whole blood cardiac marker and insight from in-hospital application in Italy by Professor Antonio. Ajana 7, question and answer session. Let us now begin with our first ajana. To officially comment our program, it is my great honor to invite Dr. Joming, acting MD BioBase Myanmar Company Limited, MD KC Healthcare Service, to deliver the opening speech. Ladies and gentlemen, please join me in welcoming Dr. Joming.
Good evening, honorable chairperson, speakers, real mind colleagues from China, distinguished guests, ladies and gentlemen. First of all, I would like to thank Dr. Wim Yau and Dr. Sujita Nai for your kind favor as a speaker and as a chairperson. And thanks all of you for your kind participation to this event. As an acting MD of BioBase Myanmar, let me share some key information about us. Actually, BioBase Myanmar company is started in 2012, so we already have about 14 years experience. Our team composed of pathologists, technicians, service engineers, logistic team, warehousing, office, and administrators to manage the team. Currently, we are providing full range of lab equipment supplied throughout Myanmar, including hematology analyzer, electrolyte analyzers, biochemistry analyzers, immunology analyzers like today's hero MCL60 NA6I, urine analyzers, of course, point of care test, and other lab consumables, etc. And we can even provide lab management service and tanking solution for lab establishment service if needed. Now it is our pleasure to host this event, introducing and bringing to Myanmar our hero MCL60 and A6I immunology analyzers. These immunology analyzers are the amazing immunology analyzers of new technology with outstanding performance, especially very short turnaround time for testing cardiac biomarkers. These machines are also very user-friendly and precise analyzers for the wide range of immunological tests, thyroid function test, thyroid hormones, HbA1c, and so on. By using MCL60 NACI at your hospital, it becomes possible to save more lives. By catching golden 30, that is within 30 minutes, you can get the test results of important cardiac biomarkers, especially for the patients who might encounter cardiac emergencies. You may save more lives. And due to the cost effectiveness, it will increase your profit margin. Moreover, These machines are very user-friendly. It will make your lab technicians more comfortable. So, thanks all of you for your kind attention and kind participation again. Thank you.
Very much, Dr. Joming, for your inspiring and encouraging opening remark. Now we will proceed with our next session. May I invite Dr. Wim Mya U, consultant pathologist and head of lab department, to deliver his opening remark, welcome our guests, and introduce the workshop theme and agenda. Please welcome Dr. Wim Mya U.
Distinguished guests, respected clinician, fellow colleague, member of laboratory team, and our valuable partner, good evening, Ming Lava. On behalf of BioBase Myanmar and RealMind, it's my great honor to welcome you all to this important event. As a pathologist and head of medical laboratory department, I have always believed that laboratory medicine is not merely a diagnosis support service, but it's also a clinical decision engine. And nowhere is this more evident than in acute cardiac care. Cardiovascular disease remains one of the leading causes of mortality worldwide. In acute coronary syndrome, we often say time is myocardian. Every minute of delay translates into irreversible myocardial damage. While cardiologists focus on door-to-bottom time, we in the laboratory must reflect on another equally critical metric, turnaround time. A biomarker result that arrived too late is not simply delayed data. It is a delayed decision. And a delayed decision may mean delayed intervention. Today's program titled The Golden 30, Why 30 Minutes Biomarker Turnaround Transform Cardiac Intervention Outcome, is designed to explore exactly this intersection where laboratory efficiency meets life-saving clinical action. We all examine how high sensitivity cardiac biomarker rapid testing platform optimize workflow and interdisciplinary collaboration and can significantly improve patient outcomes. I would like to sincerely thank our invited speakers and clinical college for joining us, and your expertise and collaboration are essential in strengthening the bridge between laboratory medicine and cardiology. I also extend my appreciation to our laboratory staff and organizing team. Excellence in patient care is never the result of individual effort, it is a system achievement. Let us use this evening not only to discuss technology, but to redefine responsibility, because in acute cardiac care, every 30 minutes matters. With that, I warmly welcome you all and look forward to a productive and impactful this medical education. Thank you very much.
Thank you, Dr. Next, we are pleased to invite Dr. Sujita Nai, Diploma and Primary Emergency Care Fellowship in Critical Care and Cardiology, who will be presenting on Golden 30 for Emergency Management. Please join me in welcoming Dr. Sujita Nai.
Good evening, distinguished ladies and gentlemen, and respected professors and dear colleagues. My name is Dr. Sujita Nai. For those who may not know me, let me introduce myself. I have spent over 10 years in emergency and critical care, and now I serve as a clinical service co-head in Bin Hospital. So for those here I have spent in emergency medicine, I like to share some of my knowledge. from those years, the main reason became very rooted in my clinical care. That's the golden 30 minutes before admission, before troponin results, and then before cardiology review. So these are my contents, the golden 30 concept, and then ABCDE assessment and time critical cardiac emergencies, and system and laboratory integration, and clinical case, and what are the failure points and the key message. So why the golden 30-minute determines the survival? All of us already know that the ischemic heart disease, according to the WHO, it's the one of the the first leading cause of the mortality worldwide. So I'm also very grateful to have a chance to be here to present this presentation, because I'd like to share my knowledge concerning with this fast mortality causes worldwide. So why the golden 30-minute determines survival? For ischemic heart disease, in 0 minutes, the plaque rupture occurs, and then 10 minutes ischemia, the blood flows suddenly occlude, and after 30 minutes, the myocardial injury process, and 60 to 90 minutes, so the irreversible necrosis. So the first 30 minutes is very important for us to intervention. And like Sarah professor said, so every 30-minute delay increase the mortality by approximately 7%. So like Sarah said, time loss is myocardial loss. So we have 30 minutes to intervene. So for the first 5 minutes in emergency, we usually call that emergency life support, ELS blueprint, and according to the Australian guidelines, that's very important for us to save the life. The definitive treatment is, although definitive treatment is essential, but these steps, airway, breathing, circulation, disability, exposure, is also life-saving. That's we call emergency life support. For every critically ill patient, we assess like this, triage, which is the patient is critically ill, Cat 1 or Cat 2 or Cat 3. After that, if the patient is in Cat 1 stage, we assess his airway, his or her airway. If airway is patent, we continue to breathing. And if he is breathing okay, normally, respiratory rate okay, saturation is okay, we move next to the circulation, and we monitor with IV assess and cardiac monitor, and then we will continue to neurological assessment and then exposure, and also we do not ever forget the glucose for the neurological assessment. So the most importantly is the ECG is the within 10 minutes, not delay, not after initial stabilization, because ECG confirm the diagnosis. So if we see ST elevation, that's everyone know that ST elevation, MI, ECG. If we see that it's the Cat 1, we recognize as the Cat 1. It's very important. We need immediate evaluation. So ECG within 10 minutes, and we'll evaluate the patient with ABCDE, airway, breathing, circulation, disability, and exposure. After that, we give immediately comments, dural antiplatelet, and cath lab activation, and everyone knows that door to boiling time is 90 minutes. Why? These are doing, we activate the laboratory, and laboratory commence immediately the lab test. So sometimes we lose the patient while preparing. And if the cardiac arrest occurs, what will we do? So we have sent the blood test, we have informed the cath lab, and the cardiac arrest, the patient, when we occur, what will we do? Did we lose the patient? No, not yet. We have still the chance. So we activate, in our emergency, we activate the Code Blue team, and the Code Blue team members organized at the ED, and then we just start a team performance. So if the patient is shockable, we give early CPR, rapid defibrillation, and epinephrine. And if stays shockable after third shock, we'll give amiodarone. If the patient is not shockable, we give early CPR, early epinephrine, and we just found out for both shockable and not shockable, 5H5D. For everybody know that it's the reversible causes. So what are the reversible causes? Hypoxia, if the patient is corrected with the oxygen, if he is getting enough oxygen or not, and after that, hypo or hyperkalemia, so we send the blood test, and then acidosis, so we send the ABG, and also hypothermia, and for 5T, toxin, and then for tension pneumothorax and cardiac thrombosis, like that, we just identify the reversible cause because we do not want to lose our patient. We just still grab the last hope and we just make with the teamwork. And then let's hope we get the patient back. And also we have experience that the patient get back and sent to the cath lab immediately, and primary PCI done, and patient survival. So while we're preparing, although we got the patient back, the patient came back with arrhythmia. So we got the pressure, but the patient is arrhythmia, VT or VF or bradycardia. We almost experienced those images. So at that time, what we do is whether the patient is stable or not. If the patient is stable, tachycardia, we have more chance. If the patient is unstable, so with unstable, which will determine the unstable features. Those are hypotension, shock, and reduced consciousness, and then chest pain. If unstable and tachycardia occurs, we just give synchronized cardioversion. And if the patient is in bradycardia, symptomatic bradycardia, with the unstable features, we give atropine. If it's not improving, we just give inotrope infusion and or pacing. So what about cardiogenic shock? So the patient became into the stage of the cardiogenic shock, hypotension plus hypoperfusion. We just give immediate assessment like A, B, C, D, E, airway, breathing, circulation, disability, exposure, and the ECG, and the lab test sent simultaneously, and we give initial stabilization with oxygen, IV assess and monitor, and we just give inotropes and identify the cause, and we just give definitive treatment. So let's continue to the system-based parallel workflow. So we just give immediate treatment, and we do not delay the treatment awaiting the results. It's parallel management. So we just give a high sensitivity troponin, which in our hospital, its turnaround time is 45 minutes. We correct the potassium, magnesium for prevent arrhythmia. For ABG, like I said, for reversible causes, hydrogen ion acidosis to correct that. For serial lactate monitoring, for reperfusion assessment. So we activate the emergency team. When the patient arrives at emergency activates the laboratory, and laboratory commences immediately. And also, cath lab is also alerted, and the ICU is also alerted. All at the same time, not sequential treatment. If there's a sequential treatment, it will delay our patient's survival. So, and also communication clarity impacts mortality. So what about the laboratory contribution in the golden 30? While reperfusion strategy is activated, high sensitivity troponin confirms myocardial injury, and also baseline renal function before the contrast exposure if we went to the cath lab. And for electrolyte correction, prevent arrhythmia, like I said. And also ABG in unstable or short state, we can correct. And for lactate, for perfusion assessment. So time-sensitive decisions are clinical. Laboratory data refines risk and guides the patient's safety. So laboratory tests support stabilization, but they must not delay reperfusion. So what about the availability of the HS-TROP less than or equal to 30 minutes? So speed plus precision will lead to the better survival. What about speed? Rapid availability enables immediate risk stratification and also will speed up the early invasive decisions. Yes, and also precision for quantitative value plus delta chain improve our diagnostic accuracy. And what about monitoring? And if we monitor TROP-T, we might be able to track lymphocytes and detect reinfarction and also assess the reperfusion success. What about the system impact in our ED? We have set a KPI for door to balloon time, what is the door to needle time, and if we got the availability of HS-TROP-D less than and equal 30 minutes, we will reduce door to decision time and improve our ED efficiency. That's our quality KPI. So HS troponin post-diagnosed but must not delay reperfusion. That's one thing. So we continue to the clinical case scenario application. 55-year-old patient came to ER with acute chest pain. He is diabetic. He's a smoker. He attributes his symptom to indigestion from spicy moringa. Everybody knows our famous Burmese cuisine breakfast. So in a golden 30, we don't negotiate with indigestion. If the patient present with cardiac sounding chest pain, we just set him as triage category 1. And then we just commence immediate evaluation, A, B, C, D, E, like I said. So in the golden 30 minute, so 0 minute arrival, 5 minutes, within 5 minutes, we get A, B, C, D, E. If we see airway abnormality, we just treat it fast. If we see breathing abnormality, we just treat him fast. And then we'll continue the definitive diagnosis. In 10 minutes, ECG, 20 minutes, decision, and 30 minutes, reperfusion if the patient is in the state of the coronary occlusion. So those are the parallel actions. So ECG, 10 minutes, decision 20, and action 30. And we send the patient blood test to the lab. And HS-TROP-T came to back at 28 minutes with 3,200 nanogram per liter. So high risk STEMI confirmed. We alert ICU, prepare for post-PCI, and send to the cath lab. So the first 30 minutes determine the patient survival. So like in the very first slide I just said, every 30-minute delay just improve the patient mortality rate about 7%. So that's very crucial. So what are the golden 30-minute failure points? Mostly those are the faults: delay ECG, laboratory turnaround time delay, and then hesitation, activating the cath lab, and interdepartmental communication gaps, and lack of the protocol ownership. The problem is really knowledge. The problem is just the system. So our key take-home message is ECG decides and laboratory supports and system save life. So our golden 30-minute is not just a very crucial for our patient survival. So if we respect our first 30 minutes, we will be able to, I'm quite sure that we'll be able to save the lives of our patients. Thank you very much for your attention.
Thank you very much, Dr. for the insightful and practical presentation. Now we move on to the next session. Please welcome Ms. Cody, Real-Mind Marketing Specialist, who will present on Real-Mind whole blood cardiac marker, performance and clinical application. Please give her a warm welcome.
Good evening, everyone. My name is Scotty. I am marketing specialist from RealMind Biotech, and very honored to be here today in Myanmar to share with you our RealMind whole blood cardiac markers, its performance, and clinical applications. And we will start with a brief background introduction of cardiovascular disease. We all know that it's such as heart attack and stroke, and also that pulmonary embolism are leading causes of death globally. And in the emergency room, I think that chest pain is one of the most common reasons to attend the ER. And study shows that up to 20% of patients might be misdiagnosed or discharged too early due to delayed or inaccurate testing. And so here is a reality that time is muscle, time is life. So that's why our leading hospital in China have established the specialized chest pain center to fast track the diagnosis of ACD. Now, what is important to understand that they are not just an organizational change. The chest pain center standard have set a clear requirement that you can see that nurses, doctors, and lab technicians in emergency department need to make sure that the test readout, for example, the troponin and D-dimer, can be obtained within 20 minutes after the blood draw. So it's not just a goal or recommendation, and it's a standard that the chest pain center must need. So how do we meet the 20 minutes challenges? Let me walk you through the traditional lab testing pathway. The traditional lab testing follows a long path from the blood draw, then you have to do the centrifugation, and after then you do the on-machine testing, and then you get the test result. It will take around 30 minutes to 90 minutes. And for whole blood testing, it will be much faster. Now look at it. We only need first blood draw, then we do the directly to the analyzer to do the test. Then you get the report result. It will take around 15 minutes to 20 minutes. So this is a power of whole blood testing by removing the most time-consuming steps in the traditional workflow, so we can cut the turnaround time from 90 minutes to down to just 20 minutes. This is why we do the whole blood. And I would like to share our guideline in China's recommended diagnostic pathway for chest pain. And blood sampling should be performed immediately to complete a panel of biomarker tests, enabling the clinicians to make critical decisions in 4 key areas. The first is disease classification. Then they can do immediate treatment, also identifying the high-risk patients. And last, evaluate should heart failure be considered. And what kind of solution that RealMind offer? That we offer a comprehensive cardiac panel with 9 key markers. Most of them can support whole blood, and all of them need minimal sample volume and with fast turnaround time. Then we can support the key clinical decisions in the ER. Next is our MCL60 analyzer. We can think of it as a POC-like solution that delivered lab result. First, it's a fast way to managing the acute patients. Then it's an accurate way it can deliver reliable results that correlate with central labs. And third, it's very convenient. It's easily to fit in and easy to operate. So in short, fast result, accurate answers, and a workflow that fits your emergency settings. Now let's look at some of the performance validation data. The troponin, we all know, is the gold standard for diagnosing many myocardial infections. A high sensitivity troponin assays allows us to detect very low levels of cardiac injury, which means we can rule out the heart attack patients faster and identifying more patients at risk. In 2023, that RealMind commissioned the China Association of Medical Equipment POCT branch to conduct an evaluation at Beijing Chaoyang Hospital, and this hospital's emergency department ranked the top 1 in China. more than 1,000 samples were collected to perform this evaluation. And here we can see that according to IFCC guidelines, a high sensitivity troponin assay must meet two requirements. The first, it should have a coefficient of CV less than 10% at the 99th percentile. And second, it should have the ability to make sure that troponin levels about the log D in at least 50% of healthy individuals. And the result we see from the report that our CV is far exceeding than the 10% requirements. It's below 3% for both plasma and whole blood assays. And when it comes to the detection rate, and Wilmi high sensitivity troponin T has a detection rate more than 95% for both plasma and whole blood assays, surpassing the requirement of guidelines. And this slide shows that our test result has a strong correlation with ROCH. The R-squared is more than 0.99. And also the correlation between whole blood and plasma is also more than 0.99. So whether you are using whole blood or plasma, you will get the same reliable result. And it's not just troponin. We can see that our other cardiac markers, for example, NT-proBNP and MYO and CKMB, also show very superb correlation data. And there I want to mention more that some companies like Roche, they may don't do the whole blood test because if they use a whole blood sample, their instrument itself may lead to the risk of electric communication. But our Realmind company, the R&D development their own patent technologies so they can conquer all the challenges by using whole blood test and deliver the reliable result. And I'm gonna share another evaluation report at Wuhan Asian Heart Hospital. We did another additional evaluation to assess the limit of detection. It's a key indicator of assay sensitivity. And the result was very clear for all the three samples, serum, plasma, and whole blood. The log D was confirmed at 1 picogram milliliter. It means that our Realmind high sensitivity troponin T assay can detect even the smallest amount of cardiac troponin chain release and enables early confidence in clinical decision making. And this is another special validation report. It's our perform validation in Germany. And Realmind partnered with Roche Diagnosis for an independent evaluation of our cardiac markers on the MCR60 system. As we all know what Roche is, it's a gold leader in cardiac marker testing, and their troponin assays are the gold standard used in laboratory worldwide. So I think Roche saw something in Realmind special, so we came together for a performance cooperation. Now let's look at the sum of the data. For high sensitivity troponin T, they tested both whole blood and plasma because in the real world may be unique flexibility for the sample types. And the result was consistent across both sample types with CV less than 3%. And when they compared our result to their own gold standard assay, and the correlation was more than 0.99. So the results are very identical. For NT-proBNP, they focus more on the whole blood because it's a sample type you use more in emergency settings. And again, the performance was outstanding. At some levels of precision, the CV is less than 3%. And also there have some correlation with Roche. The R is more than 0.99. Here is the last chart that I showed. The IFCC, the full name is International Federation of Clinical Laboratory Chemistry. So it's the gold standard reference for laboratories and clinicians worldwide. And we, Realmind, are the only company with both high sensitivity troponin T and high sensitivity troponin I assays, both selected for the IFCC reference list, and achieving the highest numbers of approved projects and instruments among all the candidates worldwide. And next, I would like to share some academic recognition, but because of time, so I'm gonna skip very quickly that we conduct a study to establish the 99th percentile upper reference limits for both high sensitive troponin T and high sensitive troponin I on the MCL60. And our assay also showed excellent correlation with Roche, and also in whole blood testing, the sample type used in emergency settings, the performance was also very outstanding. And we also do research on NT-proBNP on MCL60, and results show that MCL60 is a very reliable diagnostic tool and perfectly suitable in both central laboratories and also as a POC-like analyzer in emergency settings. Then we took a step further. We explored the age and gender-specific cutoff values can help for early detection of AMI and enhancing the diagnostic accuracy and improving the clinical utility. So this research was also published in the leading domestic journal. And finally, let's come to our final section. And honesty is the most exciting part because after all of our introductions and data and all the research, I think we all want to know the real question is, how does it work in the real world? So the MCL60 work in busy emergency department with real patients, with real clinicians and real challenges. And this is where I want to highlight that something truly significant, that our partnership with Roche Diagnosis in July 2021, that RealMind and Roche Diagnosis officially announced a cooperation plan that Roche Diagnosis become the agent of clinical department in mainland China for our star product of ML60. And along with other clear reagents, including cardiac markers, inflammation markers. And then the installation followed of the MCL60 is being rolled out across major hospitals in China in many different cities. Especially in this hospital in Tianjin First Central Hospital, it's a 3A rank hospital, and in its emergency department, 7 MCL60 analyzers were installed in 2022, handling all cardiac and sepsis markers testing from the ED. So beyond all the installations, we also actively engaging with the medical community. We take part in the major conferences, hold online and offline activities like today, and reaching thousands of clinicians. Also, we can also organize the distributor training programs. Until now, around 200 hospitals are now using RealMind cardiac markers in China. And more than half of them are used in leading hospitals, including the following. You can see the chat, hospitals in Beijing, in Shanghai, for example, Peking Union Medical College Hospital. The installation is in ICU, and Huashan Hospital of Fudan University. It's used in the clinical lab. Our installations overview, it covered most provinces of China and approaching 1,000 numbers. And we all know, I think it's just a beginning. And thank you for your time today. I hope they will give you the confidence of what RealMind can bring to you in the hospital and your emergency department and also your lab. So benefits of patients is our last goal. And at last, I want to highlight our slogan of RealMind is for better diagnosis. Thank you.
Thank you, Ms. Scotty, for the informative and insightful session. Now, ladies and gentlemen, we come to a very special part of tonight's program. We are deeply honored to have with us Professor Antonio, President of the Italian section on the European Ligand Assay Society, Joining us online from Italy, Professor Antonio is presenting on performance validation of whole blood cardiac marker and insight from in-hospital application in Italy. As Professor Antonio is joining us from Italy and there is a time zone difference, we truly appreciate his time and effort to be with us this evening. Professor, we are honored to have you with us. May I now invite you to begin your presentation?
Thanks so much. Good evening to everybody. I am very pleased to be here this evening with you, and I can share with you my experience with troponin with the MCL 60. I work in lab from 80s, and the first 35 years I worked in immunoassay, and now I moved in the last 10 years in another region of Italy. I am the director of an hospital with about 500 beds, and my lab cover all clinical needs. I want to share with you my presentation that some things was already
Antonio, scusa, abbiamo un problema di audio. Antonio, abbiamo un problema di audio. Conviene staccarsi e ripartire. Paola, lo dici tu in sessione? Okay.
Hello to everybody. We apologize for the connection. Dr. Fortunato will check another connection, probably more stable. Please be patient, just few seconds until Dr. Antonio will connect again. Thank you so much.
Actually, this lady is our Italian customer. She also has. Okay. Mi sentite adesso?
Adesso sì, Antonio.
Now we try again. I leave again the word to Dr. Fortunato. Please, Dr. Fortunato. Thank you.
Okay, I was just sharing with you my experience with the instrument, and before I will recap some things was previous presented by the speakers, but what we need is a diagnostics sure for acute myocardial infarction, because at least 10% of clinical case in an emergency department is related to cardiac pathology. What we know is that in the last 20 years, diagnostics of cardiac syndromes were changed 3 times in a radical way, and the focus was on troponin and also on the performance of troponin. We changed in last years 3 times the definition of myocardial infarction. And what is the evidence that if there is elevated troponin values, we have a cardiac problem, a serious cardiac problems. And when we...
Antonio, scusa?
Sì? Sì?
Non vediamo la presentazione, vediamo te, ma non vediamo la presentazione.
Ok.
Ti avviso appena lo vediamo.
La vedete?
Non ancora? Ok, però non abbiamo visto la precedente, non so se vuoi ripartire. Sorry again.
Okay, what we said is that the change of definition of myocardial infarction was changed 3 times in the last years, and every time was based on cardiac troponin performance.
Non ti si sente.
Beh, non si sente per niente o si sente poco?
Io sento
Male,
Paola.
vai e vieni.
No, io sento e non so se lì sentono.
Meglio togliere il video.
Okay. And what is the meaning of troponin is that when there is an elevation of troponin, we have a myocardial injury. The serious of myocardial injury is defined on the level of troponin. When a patient came to the emergency department, can have very different kind of presentation with just a few symptoms to from just a few symptoms to cardiac arrest. But we can have signal from ACZ and from troponin, and the street to what is the final diagnosis is derived from these 2 parameters, HEG and troponin. What we know that is very important to rule out the patient in a very few time if there are no cardiac problems. And stay on the other side to rule in the patient if there are necessity of other therapies. And this decision can be made on a valuable troponin assay. Each different system has different performances in troponin analytical performances, and so there are different cutoffs that should be used in each lab. Each lab needs to know what is real cutoff. In 2023 European guidelines, there are some well-defined caveats. Conjunction with every decision should be done with conjunction with available clinical information. The algorithm is proposed of 1 hour or 2 hour delta detection of troponin should be not applied in general population, but only in selected patients. In the protocol of detection of troponin is independent from the presence or absence of chest pain. The serial, the detection of troponin is needed if the clinical suspicion remains. The use of the short protocol of 1 hour is independent from the local turnaround time, because you can draw the samples also if is not available the first result of troponin. But what is needed is to compare the two results to make the decision. As I said before, the difference of a 1 hour protocol, 2 hour protocol algorithms depends on the method used. So we need to know if the performances of our method. What the problems in the detection and the use of high sensitivity troponins is the sample transport, the turnaround times, and the workload that there is in the emergency department. And what is the difference between use of a central lab of a point of care like tests? If the two systems has the same performances. Can you see my presentation?
Okay.
Okay. So the difference, if the performances of the two methods, central lab or point of care, is on time, if on turnaround time, if the performances are the same. And what we know is the benefits, both clinical and economic benefits, are based on the speed, on the accuracy, and assay specificity. We know that if we have a good turnaround time, we can decide if the patient is to rule in or to rule out in 75 of the case. We have a good clinical decision in 95–99% if we have a good cutoff, and we use the right cutoff for our method. And we have also advanced not only economical, but we can have the confirm of acute myocardial infarction within 1 hour, a rapid, a very quick rule out of the patient if the troponin is very low, and also to stratificate the risk of the patient when we have to transfer to the coronary intensive care unit. And also, as it was said before, with the time, if we are very fast, we limit the myocardial damage. Economic benefits. We have a quickly movement of people in the emergency department. We have a lower hospitalization cost because we discharge very low risk patients. we use a good troponin. We have we save 25 of unnecessary procedures, and we have at the end of the year we save a lot of millions of money. These things was not said by me, but we have data from literature, also very recent literature, and we can be sure that a good use of troponin can save lives and money. What is the difference between the use of a centralized lab method and a POCT test? What is, when we use POCT, normally we use whole blood, and we introduce, using this matrix, some variability, some variabilities that we don't have in central lab. One of these is hematocrit effects, because we know that samples, whole blood samples, can vary a lot for hematocrit samples, and the use of the RealMind NCL60 as a module for normalization of hematocrit value for each samples. So the instrument was already presented, but as a declared performance very, very good, and as a very high throughput. So this is a simple to use system as a point of care, but is also with high throughput as a laboratory, central laboratory test. Also, we have the system as a possibility to have a good autonomy of performances, because as up to 192 cuvettes on board, so it can work a lot of times. As the kit has all you need to perform the test. And what is important, I already said, is that there is an integrated module that can adapt the results on the base of the hematocrit value. We tested the systems in comparison with different central lab analyzers, of the most used analyzers in the central lab for troponin T, and we verified, following the international protocols, the performances declared by the manufacturer, and we had a very, very good results, because this is for troponin T, the performances for troponin T as CV, and you say that the cutoff of 10% is very, very, very low. And also one of the required characteristics of the high sensitivity troponin is to differentiate males and females. And here you see, along the different age of samples of patients, you see that there is, after 55 years, there is a difference, a clear difference between the levels of troponin of females and males. And this is one of the required characteristics of the troponin I sensitivity. This is a comparison of troponin T with Roche Alexis and the CLA60, MCLA60, and you see that there is a very good correlation demonstrated also in this Bland-Altman diagram. And this is the data we obtained with replicates for all the measure. And this is the difference of precision profile between whole blood samples and the plasma samples. So you can see that the difference, there are no differences between the two kinds of samples, because so that we can assess that the performance of the system is independent for the kind of samples used. But the advantage of use whole blood samples with the correction for hematocrit is very, very important to save time, pre-analytical time. And this is the data we obtained to detect the 99th percentile for male and female, that you see is quite different. And this is the correlation of whole blood with Roche. And you see this very, very good correlation. And this is the same evaluation data for the same evaluation for troponin I. So this means that on the same system, you can choose what kind of troponin to detect, both I or T. And this is on troponin I in whole blood compared to Roche. And as was said before, we performed also evaluation for NT-proBNP. That is a very important test for differential diagnostics in emergency department. And we concluded that the test was very, very, very good. These are the results we obtained. We followed also here the international guideline, and this is the precision profile. You see there is a very, very low NT-proBNP levels detected with a 10% CVU. And this is the comparison with Roche and also with another instrument that use whole blood. So it was directly compared whole blood matrix with two different instruments. And you see that this is very, very good correlated. And previous was showed also data from D-dimer. That is another important parameter in emergency SI. And as the same instrument, you have available a very large menu of methods, because, for instance, we tested also interleukin 2 and 8, and you see that there are very, very good results. So, in conclusion, MCL60 is an hybrid instrument capable to combining speed with high analytical quality. I think this is the very important feature of this instrument, because you have high quality, speed, easy to use, and a wide menu of tests you can perform on the same instrument. So I thanks you for your attention. I am apologize for technical problems.
Thank you
And
very
Antonio,
much,
please.
Professor Antonio, for the excellent and informative presentation.
Antonio, please, we received 2 questions. Would you like to answer them, please?
Yes. Okay. Can you see me?
La risposta.
Ti sentiamo.
Thank you, Mr. Antonio, and for your kind presentation. And now this is time, because of the time limitations, let me ask the questions with email to you. And I'm very grateful if you can answer our audience questions with the email again. Thank you very much, Mr. Antonio.
Yes. So I can see.
Next, we are honored to invite Dr. Zawang to share practical experience and clinical insight. Please welcome Dr. Zawang.
Good evening, respected professors, colleagues, and healthcare leaders. I'm Dr. Zawang, and I have been working in laboratory services across both public and the private healthcare centers in Myanmar for over 20 years. First of all, I would like to extend my deepest gratitude to all the respected professors and senior doctors who have joined us today. And to my beloved mentors, Dr. Tantra, and who shaped me into who I am today. Both personally and professionally, I am forever grateful. And to my friend Dr. Jo Min and Dr. Wimia Wu, who have always supported me like my own brothers in every possible way. And thank you for your being my pillars of the strength. I also want to sincerely thank all my fellow colleagues, my technicians, my teammates, who have come here today to support me. Your presence means so much to me. And I also want, as I cherish all your kindness and encouragement, I wish you all good health and happiness. Today, I would like to share our practical laboratory experience about the role of the whole blood client technology and emergency management. My presentation will focus on two key areas. Two key areas: healthcare service impact and the laboratory quality. Today in healthcare services, emergency care is a race against time. In emergency medicine, time is the most critical factor influencing the patient outcomes, while clinicians and hospital administrators work tirelessly to deliver the optimal care. Rapid diagnosis and intervention remain essential. In today's healthcare landscape, patient certification is a powerful driver of hospital reputation and trust, often becoming the most effective form of marketing through word of the mouth. I believe that laboratory is a clinical collaborator, a clinical partner. The laboratory is no longer a passive diagnosis unit. It plays an active role in the emergency response, clinical decision making, treatment monitoring, hospital efficiency, and institutional image. At the Budiri hospitals, our laboratory functions as part of the multidisciplinary emergency team. We view ourselves as a vital link in the hospital life-saving chain, committed to delivering a one-stop laboratory services with routine results within 4 hours. And all you know, my colleague technicians and my friends all know that we are trying to get the results as urgent as possible. And I'm also trying at my Zabudiri hospitals. We're trying to get the results, all the results within 4 hours. Urgent results within 1 hour. Our mission is clear: to support the clinicians in achieving the golden target from behind the connectivity, reliability, and the speed. About the connectivity, we have implemented the Alliance integration to the streamlined results delivery. Instead of relying on phone calls, physicians receive the structure data directly, enabling them to review the results remotely, provide immediate clinical guidance, and initiate early intervention. About the reliability, in Myanmar, laboratory standards have evolved significantly. The introduction of the advanced systems, starting with the Pentra. All my colleagues well know that about the Pentra, and later the Roche platforms. Those help the laboratories, including ours, achieve the internationally accepted levels of the accuracy, precision, and the standardization. Before this transformation, we all know that many labs face the challenges in consistency and confidence. We all know. About the speed, Roche platforms offer the analytical turnaround time as fast as 15 minutes, but practical delays persist due to the clotting time, we all know, and the centrifugation time, and the sample preparation. And then Roche and the Reamind, to overcome these barriers, Roche collaborated with the Reamind, leading to the development of the whole black cloud technology by the Reamind systems to overcome the clotting time, centrifugation time, and the sample preparation. Here is the Reamind MCL60. Here is the Reamind MCL BioBiz already got the FDA approval from the Myanmar. And the Reamind system introduced a breakthrough direct testing from the whole blood using a single EDTA tube. Elimination of the clotting, centrifugation, and preparation steps, high accuracy results within the 50 minutes, physician notifications within the 30 minutes, meeting the golden 30 target. Let us see how it works. We collect the blood from the patients and directly
The test begins.
This makes automatic cooperation with the 3MI and the RMI and the RUSH. And actually, this the RUSH always researching about how to get the results as urgent as possible. And they found the RMI and they cooperated with the RUSH cooperated with the RMI and the launch in the China mainland. And unlike the traditional point of contact device, RMI MCL adheres to the proper calibration and QC protocols and offering the laboratory grade reliability with the point of care test speed. As previously mentioned, Ms. Scotty expressed that the point of care test results can get within the 15 to 20 minutes. Then this MCL can get the results within 15 minutes, can test the results, can test the samples as urgent as possible into the analyzers. Then it meets the POCT speed and also the laboratory grade reliability. And also it enables the simultaneous multi-marker testing from a single sample, including the high sensitivity troponin, NT-proBNP, D-dimer, and the procalcitonin. We no need to break next many times. We can test many tests through one simple EDD tube. About the quality, we conducted the internal comparison between our RUSH platform and the RMI MCS system. The finding demonstrated the acceptable agreement, reliable correlations, and the clinical consistent performance. Let's see the data. Now we use the whole blood. Okay, this is NT-proBNP. The concentration testing from the only same patients, only one samples 3 times. This means that the results is first time is 10288, and the second time is the 10347, and the third time is the 10307. It means all technicians and my colleague pathologists already know that the precision. You can see well about the precisions. The precision means the quality of the analyzers. When we test the point of care test, the results may be within the 10%, maybe more than 10%. This is the high sensitivity. This is the high sensitivity troponin T running in my laboratory, testing about the MCS60 precisions. For 10 times, all are the near within the all are the 9.40, 9.08, 8.89, 9.0, 9.5, 9.3. It means the high sensitivity troponin T and the precision is very good. This is this analyzers. In addition to the whole blood cardiac markers, it can also test for the other endocrine tests and tumor markers. I already tested the MCL60 for the thyroid stimulation hormone, and the results are 48, 48, 49, 48, 49. This shows the precision of the analyzers. Conclusion, whole blood collecting technology, particularly the real-time system, making significant advancements in management emergency laboratory medicine. It bridges the gap between the point of care, the speed, and the central lab accuracy. Faster diagnosis, earlier intervention, better patient outcomes. Ultimately, it fosters a stronger trust from the patients and families, the most powerful form of the hospital reputation, and the best advertisements of our institutions. Thank you very much.
Thank you, Dada, for sharing your valuable experience with us. Ladies and gentlemen, due to time limitation, we regret to inform you that we will not be conducting a live question and answer session this evening. However, we truly value your question and academic engagement. We kindly invite all participants to submit your question to our organization team. All collected questions will be forwarded to speaker and they will respond to them via email after the event. We certainly appreciate your kind understanding and cooperation. Thank you very much. Ladies and gentlemen, may I now kindly invite our respected speaker to come to the stage for a group photo. Please join me in welcoming Dr. Joming, Dr. Wim Yau, Dr. Sujitanai, Dr. Zowan. In addition, we would like to invite 3 representatives from the REAMI team to please join us on stage as well.
Hey, Chanaru, Ria my biobase ko trial la jare. Chanaru CIE, Dr. Tanto Powen, Chanaru Mixway, the general pathologist colleague, the now technician, the Alo, Chizu Mia Itemare. Now, Chanaru, Dido biobase ne patelu, Ria mine patelu, Luate, Mimia Muri, Luate, Sata Muri, Shin, Dr. Zowan, Chanaru. Satu mimia nai ne chong pyo cha ne di ni nya ro di ma we pyo ba ba ni kong chou lai phu pyo lo ba de khamya a long ko jesu tin ma de
Ladies and gentlemen, as we come to the conclusion of tonight's CME evening, we would like to express our sincere gratitude to Dr. Jo Ming, Dr. Win Myat Oo, Dr. Suji Danai, Dr. Zowan, Professor Antonio, and all distinguished guests. BioBase Myanmar and Riemann Biotech are truly honored to organize this continuing medical education program, and we are grateful for your support and participation. Thank you once again for joining us this evening. We wish you a pleasant night and a safe journey home.